Be presenting to you today on differential diagnosis in school-based healthcare behavioral health assessment. This is a topic that is actually near and dear to my heart, and I hope to make it enjoyable listening for you. Oh, that might have been somebody getting on right now.
This is Carrie Peterson in Roswell.
Hi, Carrie.
Hi.
Kevin Whirling is here, Envision's IT support, to help us have this webinar today. And I'm Dan Rifkin. I just announced that I'm going to be presenting on the topic that you're aware of because you signed up for this webinar. Appreciate you all doing so. Differential behavioral health diagnosis in your school-based health center, also known as, if not ADHD, what is it? Especially meaningful to those of you who are working with younger students, elementary school to middle school, then it may ring a little less true for those working with high school students, but I hope to make this applicable to everybody. I recognize your names from your past webinar attendance. Always appreciate it. So you very well may know that I'm a child and adolescent psychiatrist working at Envision, New Mexico and at the UNM Department of Pediatrics. I spend about half of my time providing services in school-based health centers and the pediatric clinic, and the rest of my time I have the privilege of being here at Envision, presenting webinars, other telehealth involvement, including my telepsychiatry consultation, information about which is included at the end of today's webinar. I'm also serve on the Technical and Assistance Training Panel with the National Assembly on School-Based Healthcare. Today's webinar is on differential diagnosis, where we will explore the major diagnostic domains to consider during behavioral health assessment. This is probably the most heavily content-laden webinar I present in the series, and I am going to be making a concerted effort to really talk about the information that you're going to see in front of you on the slides rather than to merely read them to you, except where I think it's important to make a point. And there are a couple slides that you're going to find are packed with information, and probably several, for purposes of you having the information to take away from this webinar in the handout that's available to you. There's a sequel next week to today's presentation that looks more at the process of using the content that's presented today and how to use it to make the behavioral health assessment. That webinar will include the references and resources for today as well. So again, today's goal is to consider the major diagnostic domains to keep in mind during behavioral health assessment. That's our goal that we want to remain oriented to. So hopefully we can move on in that direction. And here we go. We have a referral from the school about a third grade boy named Spivey. And the teacher asks, diagnose, or asks, or is it commands, or directs, diagnose ADHD and prescribe Ritalin. Such referrals are actually received. Sometimes the referral could be even more curt than that. Something like, third grader has ADHD, prescribe him Ritalin, okay? Well, does the referral make the diagnosis and prescribe the treatment? I think we all need to consider other diagnostic possibilities, and I think we all agree about that. If anybody disagrees, I expect you to chime in loudly at this time. So I'm also hoping that we can have some fun in moving through this, because while educators and administrators with a less broad view of mental health than mental health and primary care professionals have working knowledge of, may make these referrals without realizing that students may not only have ADHD, they may have something else. So this is one of these points in the webinar where I want to emphasize that although a student is referred for a diagnosis of ADHD, they often have other impairing problems that interfere with their learning. And they may be comorbid with ADHD, or they may be something else or a combination of things with ADHD. It's known that students often are referred for an evaluation of and medication for ADHD specifically. But when we do a comprehensive clinical assessment, we frequently find that these students have other often coexisting conditions that are what impair their learning. So let's consider the various diagnostic domains which feature hyperactive, impulsive, and off-task behaviors, as that really is our goal. Because numerous psychiatric problems in youth feature distractibility, impulsivity, or increased activity, psychomotor activity. And that concentration difficulties are symptomatic of virtually every psychiatric disorder in the Diagnostic and Statistical Manual, as well as many related subsyndromal conditions. Okay? So having problems with attention or concentration doesn't necessarily mean ADHD. And it's been shown as part of practice standard that a variety of other disorders can be mistaken for ADHD or can co-occur with ADHD. And this comes from the American Academy of Child and Adolescent Psychiatry, 2007, in their practice parameter for the assessment and treatment of children with ADHD. By the way, as members of the American Academy of Child and Adolescent Psychiatry, we receive these practice parameters that really posit various standards for assessment and treatment. There's also empirical support, such as numerous studies reviewed about a dozen years ago now by Madison, that showed various mental health issues underlying disruptive behavior at school, including not only ADHD, but other disruptive behaviors, makes sense, but also mood, anxiety, adjustment, substance use, learning language, and other developmental disorders. So just because a student is disruptive in class, it doesn't mean that they have ADHD. So we're finding information that says concentration / attentional problems doesn't always mean ADHD. Disruptive behavior problems doesn't always imply ADHD. Well, what does present like ADHD in students? That's really our main objective, again, to identify these major diagnostic domains that feature distractibility, impulsivity, and hyperactivity. Those are the hallmark features of ADHD, and here is the list of all of them that it may be in students who are referred for a evaluation for ADHD. I think then we need to be thinking they need a comprehensive assessment, not an ADHD evaluation. Similarly, even seasoned clinicians will refer children for, quote, ADHD meds, unquote. And similarly, there needs to be a comprehensive assessment to determine if any medication is needed, and if so, what is it to address? More than likely, it's not just ADHD, and it may not be ADHD at all. So the differential is really summarized already at the beginning of the presentation today, that it could be ADHD, other disruptive behaviors, mood disorders, psychotic disorders, anxiety disorders, problems with disrupted early attachment that impacts memory, dissociative disorders, neuropsych considerations, sleep problems, substance abuse, pervasive developmental disorders, also known as autistic spectrum disorders, or ASD, other developmental conditions, and medical conditions. Okay? So really, if you wanted the Cliff Notes version of what we're covering today, this is really it. But it's my hope that you'll take a further journey to look at what is it about these conditions, each one of these domains, that that we need to consider in assessment, and what are kind of their signature features that would tip us off whether they're present or not. Well, in order to do that, we need to look at what are psychiatric disorders and what are their causes, which brings some further objectives to define psychiatric disorder, distinguish disorders from subsyndromal conditions, and understand etiology using the biopsychosocial model. And that's really important because often criticisms are made about diagnostic considerations in the process we need to undergo an assessment because of the emphasis on the findings and the symptoms. But by understanding further what the etiology is, one comes to appreciate that the symptoms are representative of the etiology or etiologies. Well, the psychiatric disorder is described very well in the Diagnostic and Statistical Manual. So the current DSM-4, now DSM-4-TR, describes a psychiatric disorder as severe and pervasive. Okay, so it's severe enough to be present in many different settings, and it persists over time or recurs, causes impairment, and really fits with the biopsychosocial model. Well, that model initially was described by George Engel, an internist who became a psychiatrist later in his career at the University of Rochester in New York, to describe heart disease, is how he developed the biopsychosocial model. Subsequently, it was applied to asthma, other medical illnesses, various psychiatric disorders, and it explains etiology by identifying genetic predisposition and other constitutional aspects. Even with personality disorders, there can be these propensities. Psychological experiences, social and environmental factors. Well, I mentioned earlier that we will look at these various domains, and I think it makes sense to start with ADHD because we're really doing a comparison and contrast to ADHD. And when describing the list of conditions that are possible causes or contributors to somebody looking like they have ADHD, what essentially was listed here in the title are the hallmark features of ADHD: distractibility, impulsivity, and hyperactivity. Those are really the three main hallmark features of ADHD. And the Diagnostic and Statistical Manual will give a long list of different behaviors and really list them under each three of those areas. One of which is really a misnomer. The deficiency really is in concentration, okay, not in attention. It's actually a concentration deficiency rather than an attention deficiency. There's actually an overabundance of attention to surrounding events and objects, whereas the matter at hand or the object right in front of one is harder to concentrate on. And these hallmark features correspond with the three main types: predominantly hyperactive impulsive type, that is without problems with attention or concentration. On the other hand, the predominantly inattentive type, that's often referred to as, quote, ADD, while the others are referred to as ADHD. And then there's the combined type, which is all of the above. Also of note about the inattentive type, it really may be genotypically a different entity. It seems to respond differently to medication in both non-efficacious and in efficacious ways. For example, atomoxetine, known as Strattera, tends to be more effective with this kind of ADHD. That kind of medication has different properties than psychostimulants. Those kinds of facts lead people to begin, or have been causing people to think differently about the inattentive type of ADHD. The early onset of ADHD is very important, and therefore it's listed here. Typically, ADHD has its onset before first grade, okay, before 7 years old, causing impairing symptoms by first grade. So if a high school student is coming into the school-based health center and says, I think I have ADHD, I'm not able to concentrate in my classes or complete my homework, and ADHD has never been considered before for this individual, the student's problems most likely are not due to ADHD, but due to some of these other considerations. Well, in looking at etiology, as we've agreed that this is important, there's a neurologic underpinning that is abundant in ADHD. It's largely a neurologic condition. Psychosocial factors will contribute to the severity of ADHD symptoms, and so can physical factors, as I'll mention later. But commonly, ADHD probably results from delayed brain development, especially the frontal circuits. And therefore, it's outgrown by many. It can be thought of as a developmental condition, and therefore, primary ADHD is often referred to as developmental ADHD, okay? And those who have acquired ADHD, for example, due to a head injury or some other cause, have a different kind of ADHD. Maybe they have neurologic and neuropsych considerations such as seizures, such as absence seizures, that cause one to miss what's going on in class. But that's a very different phenomenon than ADHD itself. Traumatic brain injury can cause ADHD features. So can prenatal substance exposure. Insufficient oxygen and nutrition prior to, during, and after birth through the newborn period. And genetic and chromosomal abnormalities such as Fragile X, Klinefelter syndrome. Often these conditions will cause the individual to have ADHD features. Now there's another neuropsych consideration I'm just going to mention here because it can explain how some individuals who have neurologic problems that affect them in major ways in multiple areas such as attention, concentration, processing speed, the speed with which one processes information, language problems, memory, and executive functioning, being able to plan ahead and anticipate, may have a single condition that explains all of this that's described in Appendix B of DSM-4 that I'd have to say I have found useful when working with youth, usually teenagers, who have problems in all of these areas. Well, there are also the other disruptive behavior disorders, such as oppositional defiant disorder, which is really worth considering as a mood disorder because the mood is anger. No, it's not. Yes, it is. The individuals tend to be very angry, negative, hostile, and become defiant. There's also conduct disorder, which is comprised of a pattern of violating the basic rights of others and major age-appropriate societal rules where there's violation of individuals with aggression, theft, and so forth. And then disruptive behavior disorder not otherwise specified, or NOS, can be used when you have some of those features, not all of them, or you have a pattern of oppositional and defiant behaviors and there are evolving conduct problems. That's all in the area with ADHD, actually. And the one thing that it has in common, again, with the mood disorders is the excessive anger. Now, the so-called mood or affective disorders include the depressive disorders and bipolar disorders. Major depressive disorder is probably the most common, but in youth we often see dysthymic disorder, and often we see features of the two combined. There's also a nonspecific depressive disorder when there are not the diagnostic criteria met in either of the above. There's also different varieties of bipolar disorders. And it's very important to keep in mind that the major depressive disorders occur not only in major depressive disorder. Let me back up. The major depressive episodes not only occur in major depressive disorder, but in bipolar disorders as well. Now, the features of the major depressive episodes are 9 of them in total, described in the DSM-4, and you will recognize these as being described in the PHQ-9 that we use as an assessment instrument in school-based health centers and other clinical settings. Where there's depressed mood, in youth this is often irritable, and markedly diminished interest or pleasure, and that at least one of the first two needs to be present for there to be a diagnosis. And then there are disruptions of appetite or weight, sleep, energy, plus features of psychomotor agitation or slowing, feelings of hopelessness, worthlessness, or inappropriate excessive guilt, and less ability to concentrate. The difficulty concentrating and the psychomotor agitation can cause these individuals to appear as though they have ADHD. And these are features that we see more often in children than in teenagers when depressed. There also can be recurrent suicidal or death thoughts or wishes, and sometimes a suicide attempt made. Well, there's some features about depressed youth that are more typical of younger students than older students and adults. Frequently, younger individuals become irritable when they're depressed, and they have a lot of anxiety mixed in as well. They can have diminished concentration that causes them to be distracted. The younger children often have more of the psychomotor agitation that looks like hyperactivity. Okay, and that's what I was referring to in the previous slide about psychomotor agitation underlined and concentration difficulties. Those features that are underlined are those that can cause one to look like they have ADHD. Their younger children often have more somatic complaints. They also can have hallucinations. These decrease as they get older and with less severity of the depression. On the other hand, perceived hopelessness, loss of interest or pleasure, delusions, diurnal variations, and psychomotor slowing increase with age of the student. Pardon me, I wanted to go in this direction. Dysthymia, unlike major depressive disorder, which is characterized by episodes, dysthymia is more of a chronic, ongoing, low-grade depression that doesn't get to quite the severity of the major depressive episodes. And yet there are problems with concentration, feelings of hopelessness, low self-esteem, low energy, insomnia, or hypersomnia, okay, as well as appetite disturbance. And these are vegetative signs as well as symptoms that are present in dysthymic disorder. Dysthymia is frequently comorbid in overweight youth. With pediatric bipolarity, there's prominent irritability and lability. There can be the typical pressured speech and grandiose thoughts, delusions, racing thoughts, flights of ideas, risk-taking behaviors, typical of bipolar disorder in older individuals. Younger individuals may even become hypersexual when they're having hypomanic or mixed manic states. There also will be sleep disturbance. They can have prevalent hyperactivity, impulsivity, and distractibility. So the main hallmark features of ADHD are found in bipolarity. The prominent irritability is increasingly found in youth, far more than in adults. But this similarity with between pediatric bipolarity and ADHD seems to flow also because there usually tends to be an ADHD diagnosis made before the diagnosis of bipolar disorder. And while these are identified as distinct features between children and adults with bipolar disorder, it was very well characterized in a review about bipolar disorder by Barbara Geller and Joan Luby quite a ways back, 1997, who described younger children with bipolar disorder, that is, pre-pubertal onset, as a non-episodic, that is, continuous, chronic, very rapid cycling mixed manic state. Well, wow, that's a lot of adjectives. It can be thought of as the rapid cycling becomes increasingly rapid. There are terms such as ultra-rapid and ultrarian cycling, that there will be a mixed manic state because the person will be more or less up and down at the same time. They won't be fully up or fully down. So it becomes non-episodic, but it's chronic. It keeps going on. It may be comorbid with ADHD and conduct disorder, or have ADHD and or conduct disorder features in the initial presentation. So a lot of times youth with bipolarity will be diagnosed with ADHD when that may not be what's going on, or that might be part of the picture. Psychosis also can cause youth to appear as though they have ADHD, both when it's an active or acute psychosis, as well as childhood precursors to schizophrenia and related chronic primary psychotic disorders, known as early onset psychosis. Well, the actively psychotic youth, those I mentioned and are listed first on this slide, may be distracted by hallucinations and delusions. They can be impulsive and or hyperactive due to the derailment of their thought train. They can respond to hallucinations and or delusions. They also can become hyperactive due to catatonia, which is not usually what people think of as catatonia, but there can be catatonic excitement or restlessness in psychosis. And individuals with psychosis may be depressed, manic, using substances, or psychotic due to another cause. Well, this is a listing of the differential diagnostic causes of psychosis, ranging from substance use, which would be an induced psychosis. Mood disorders can cause youth, especially young people, to have psychotic features such as hallucinations. Post-traumatic stress disorder is known to cause hallucinations in young people as well as adults. Schizoaffective disorder, very much like schizophrenia. There also can be psychotic symptoms in schizotypal personality disorder, delusional disorder, psychotic disorder, and so forth. When I think of what's really important when looking at the psychopathological trajectory of students who have psychotic features is that schizophrenia presents itself in ways that are different than very active acute psychosis. The onset is much more insidious. It typically will emerge early with various developmental and behavioral problems, followed by gradual onset of a fuller psychotic syndrome. Males are thought to have earlier insidious onset following early signs of abnormal development. Now, these are individuals who often will have depressive symptoms and conduct problems. But as it was mentioned earlier about abnormal development, there will be attentional problems and hyperactivity often present in these individuals. Often the diagnosis of ADHD or ADD is made by elementary school for these individuals, and it will precede a diagnosis of schizophrenia. So in other words, educators, administrators, and others in the school will think that the child who's developing schizophrenia has ADHD. Now, the developmental deficits in these individuals are prevalent. 1/2 to 3/4 of children studied had developmental deficits in language, motor functioning, social functioning, and adaptation. And academic difficulties are common, resulting in 1/2 of these individuals to be retained and 65% having educational placements prior to the onset of psychotic symptoms. These individuals will often have peculiar mannerisms and interactions that are more typical of the pervasive developmental disorders. Well, there's also the anxiety disorders, and they're listed here in the order of age of onset. So specific phobia is known to have probably the earliest onset among youth. And this list really parallels the progression of cognitive and social maturation of these kids and their chronologic ages. So specific phobia is an anxiety disorder of much younger children. Separation anxiety of somewhat older children. Generalized anxiety, significantly older children, as well as the others. Also here, you'll see panic disorder listed as number 6. And a note made that in panic disorder, the panic attacks are untriggered, whereas other conditions such as PTSD or even depression can trigger or have triggered panic attacks. Well, in separation anxiety disorder, there's recurrent excessive anxiety, fear, worry about separation from home and major attachment figures. A fear, if you will, that something bad is going to happen, usually toward a loved one, if they're left home. This is very typical in situations where there's domestic abuse or threats of violence in the home, and the student is worried about what's going to happen when not there. Repeated are physical symptoms, especially gastrointestinal and headaches. This is a major cause of school refusal. However, depression, psychosis, and other anxiety disorders also can cause school refusal. Generalized anxiety disorder involves anxiety in many respects, such as excessive worry and anxiety about numerous events, activities, including performances at school, and that's not only performances with the band or solo on stage, but could be about social interactions. Symptoms usually include restlessness, concentration difficulties, irritability, insomnia, fatigue, muscle tension. And there likewise can be somatic complaints. Now, this is the one area in the DSM-4 that used to be a separate generalized anxiety disorder for children called overanxious disorder of childhood, but now it's included with the adult form. Excuse me, PTSD is huge. It involves persistent re-experiencing of past trauma during repeated behaviors or repetitive play, in which there are intrusive recollections, nightmares, flashbacks, somatosensory stimulation or recall, and emotional recall. Often it includes hallucinations and dissociative episodes, as well as panic attacks. There are concentration difficulties, reactive aggression, hypervigilance, and exaggerated startle. These are individuals who, at least by the time they turn middle school age or high school age, start to anticipate that they're not going to live very long, when that may not at all be the case. Now, I included memory and attachment considerations because they're so influential that implicit memories of early childhood abuse, witness violence and chaos often causes youth to be very unsettled in ways that they're not even aware of because the trauma may have occurred when they were so very young. Disorganized attachment can cause one to become very hyperactive, impulsive, and have difficulties focusing. Typical dissociative disorders include depersonalization disorder and dissociative amnesia. Just included here to make the point that there are so many different causes, including sleep problems, because we do have an epidemic of insufficient sleep. Signs of sleep deprivation actually may be diagnosed as ADHD in 10 to 20%, because these individuals will have difficulty concentrating, they'll become irritable, impulsive, hyperactive, take risks, become aggressive, have impaired learning and academic performance. It's mentioned here that children with ADHD are found to have more fragmented sleep, though the same quantity as controls. And this is independent of prescribed psychostimulants. So in other words, difficulties sleeping have not been linked with or dependent upon psychostimulant medication. Substance abuse includes stimulants, whether it's cocaine or methamphetamine, that induce ADHD features, or substance-induced states with distractibility, diminished concentration, impulsivity, and agitation. Pervasive developmental disorders can cause individuals to appear as though they're inattentive, that they can't focus, that they're hyperactive and impulsive, and this is mostly due to how they are attracted to objects in their surrounding, rather than true ADHD. In the DSM, we'll talk about how ADHD cannot be diagnosed in these individuals. There are some other developmental considerations. Delayed but progressing development. That would be the immature child or adolescent who seems to be maturing but more slowly and is behind peers in that regard. Learning and language disorders can cause youth to become bored and have difficulty understanding situations, paying attention, or expressing themselves. Young ages. Very young children tend to have difficulties concentrating. They're often impulsive and hyperactive. And the fact that they are doesn't mean that they have ADHD. So a referral of the very young child or children is something to approach cautiously. Then there are the medical mimics, such as somebody taking psychostimulant medication when they don't have ADHD, okay? Without is what's abbreviated there. Albuterol, theophylline, other medicines that are used for treating asthma. An albuterol inhaler, too much taken, can cause one to become hyperactive and even inattentive. Diphenhydramine, or known as Benadryl, is known to cause sedation, but some individuals have a paradoxical activation to it. They could become hyperactive, not being able to focus very well, and could be very impulsive. Thyroid disorder and other metabolic problems can be a culprit, especially when hyperthyroid is present. Lead poisoning, central nervous system infection, peripheral infection, including Epstein-Barr virus and other viruses, and other medical conditions. So here is our list of the differential diagnostic possibilities for the ADHD hallmark features of distractibility, impulsivity, and hyperactivity. And I applaud you for hanging in through this survey because it's pretty extensive, and as mentioned earlier, there was a lot of information in there. And to think that that's not all, because we have comorbidity that can become important for us to understand in a couple different ways. Clinical assessment often reveals that there's more than one disorder. Coexisting conditions other than ADHD can combine to mimic ADHD on the one hand. On the other hand, disorders that mimic ADHD can coexist with the ADHD. So here we have a situation where somebody who has ADHD features doesn't have ADHD at all, but they have a dysthymic disorder as a depressive disorder. They have an anxiety disorder, which here is PTSD. They have disruptive behavior problems, eventually diagnosed as conduct disorder. And they have a neuropsych condition, which is traumatic brain injury. Together, those four conditions can combine to present like ADHD. There also are disorders that coexist with ADHD. ADHD is a condition of comorbidity, if you will, in 2/3 to 75% of cases. Again, pediatric bipolar disorder is found to coexist with or initially present with features of ADHD and or conduct disorder. And it's really important to assess and treat not only what's thought to be the ADHD, but the coexisting conditions. So in comorbidity, we see these overlapping domains where depressive disorder, disruptive behavior disorder, anxiety disorder together can look like ADHD. And these are, and then there can be the conditions in which there is something that is coexisting with ADHD, such as oppositional defiant disorder, conduct disorder, features of both, learning disorder, language disorder, mood disorders, anxiety disorders, movement disorders such as Tourette's syndrome. And as far as one's personality, those, according to the late Dr. Denny Cantwell, those individuals who do have ADHD tend to lack a social savoir-faire in being able to read social situations and respond accordingly. With ADHD, we see overlap with coexisting conditions such as disruptive behavior disorder and bipolar disorder. So far, we've reviewed the differential diagnosis for ADHD and other disruptive behaviors, and also the comorbid or coexisting diagnoses. Next, we're going to briefly look at what are the contributing, exacerbating, and or other associated factors. Well, we talked earlier about how thyroid conditions can cause one to present as though they have ADHD. It can also contribute to that picture or exacerbate that picture. So can being overweight, having a chronic illness, or an acute illness. And those in turn can cause increased psychosocial factors that we also need to take into consideration. So in summary, students referred specifically for evaluation of and medication for ADHD frequently have other often coexisting conditions that impair their learning. Various diagnostic domains feature hyperactive, impulsive, and off-task behaviors. The comorbid disorders and exacerbating factors also contribute. Well, I would want to ask if there are any questions or anything you would care to discuss at this point.
So, okay.
Thank you. Well, today we've explored the various major diagnostic domains to consider during behavioral health assessment. Next week, Monday, January 14th and Tuesday, January 15th at 3 p.m., we'll look at how these differential diagnostic considerations are used to make diagnoses in school-based health center behavioral health. So I thank you for joining us today. I'd want to mention that there is telepsychiatry consultation available to support you with your work and to help you serve your students. And this gives the instructions on how to access it through Clancy Tarbox. And with the new semester, the 4 hours a week will be available from 2 to 3 p.m. on Monday, Tuesday, Wednesday, and Friday. So if you wish to receive your CME or CEU for attendance, please state your name at this time.
This is Carrie Peterson.
Thank you, Carrie.
Thanks, Carrie. Anybody else? You may have muted yourself, so you may have to hit star bound to unmute.
Okay. Well, from all of us here at Envision, we thank you for joining us this afternoon. It's really been a pleasure having you. And please keep in mind the sequel for next week that I hope will help you get even more out of today's presentation. Thank you.
Okay, thanks.
Thank you.